Well, I'm here to present PEAK, Portable Eye Examination Kit, which is probably one of the most exciting projects we've been involved in Department of Biomedical Engineering in Strathclyde. And what is it about? Well, it starts from a consideration, a simple one, and it is that there are more or less 40 million people who around the world are blind. Now, this number looks big, but it looks even bigger if we think that out of these, 4 out of 5 could either be treated or could have avoided being blind in the first place. And if we look a bit more into the numbers, this is a figure by Andrew Bastaros, London School of Hygiene and Tropical Medicine. Now, what Andrew has done here, he has taken a map of the world, divided it in areas, and scaled each area proportionally to the number of blind people who reside there. And we see where they reside, Africa, India. If we take the same map and rescale it by the number of eye doctors that work in the same areas, we get this. And quite unsurprisingly, the highest number of blind people reside where the lowest number of doctors are. Now, this looks obvious, but if we look at the real the actual numbers, they give us some information. Let's take a country like Kenya, where we have the exact numbers. Kenya is 40 million people. In Kenya, there are 86 practicing ophthalmologists, and more or less half of them work in big clinics in Nairobi. This means that the rest of the country is left more or less with 1 doctor every million people. And this effectively means that we cannot expect 1 million people to get their eyes checked by a doctor, by one doctor. We need to identify the patients who need eye care directly in the community. And effectively, even in a low-income country, the healthcare provision is not the bottleneck. The bottleneck is identifying the patients. And this is where PEAK starts from. PEAK starts from a study by Andrew Bastaros, London School of Hygiene and Tropical Medicine, who in 2012 went to Kenya to look and to screen approximately 5,000 people distributed over 100 centers, most of which rural, and screened them for eye disease, and this was the situation. So a team of people, bulky equipment, and everything that's needed to run this bulky equipment in rural areas, so generators, tables, chairs, whatever not. Bulky equipment to be shuttled around in often complex situations, hardly any roads, identifying clinics, and in this day we were lucky that we had a concrete floor, no electricity, we had to deploy generators, and this would be a typical situation. The clinic has been set up, people would travel for days on foot to get their eyes checked. Now, of course, this is not sustainable. And so Andrew had the idea of attempting to take all these tests onto mobile phones. Why mobile phones? Even in a place like Kenya, there are more people who have access to mobile phones than people who have access to running water. And this means that mobile phones are effectively friendly objects of daily life. And this has 2 implications. First of all, there is mobile phone literacy. People know how to use them. And the other, very importantly, they're perceived as friendly objects. If I think about myself, I'm a medical instrument designer, and in 1997, I needed an MRI scan. And was taken to a big room, one of the first high-field machines. They put me earplugs, then earmuffs, then stuck me into a tunnel, sealed the tunnel off in total darkness, and turned off the most hideous noise I can remember. And I was terrified, and I'm an instrument designer. I imagine a person who in Kenya has never seen a doctor asked to put their head on a machine like we're used to when we get our eyes measured, bright light shone into your eyes, and then being told that you need your eyes open, cut open to be able to see again. Of course, they're not happy to have this done. While mobile phones are perceived as friendly objects. So what is PEAK? PEAK is a comprehensive set of high-quality eye tests implemented on mobile phones. Now, what does PEAK do to the present day? It does a number of tests that are the tests normally required in the community to screen and identify patients. We do visual acuity, so how well we can see. We do color and contrast sensitivity. We image the front of the eye for cataract. We image the back of the eye. We take patient records. I can't go through on how we do all these tests, so I've taken a few selected examples to show a bit the type of issues we encounter when we implement these tests on the phone and what really this means. Let's start with a simple visual acuity. Now, we're all familiar with this test. We are asked to look at a target. In our countries, it's with letters, asked to identify letters of progressively smaller size. And from this, the ophthalmologists can understand how well we can see. Now, bringing letters to a mobile phone in itself is a trivial task, because mobile phones have a screen. Sorry, for some reason it started automatically. Okay, mobile phones have screens. What is not so trivial is the fact that the operator, to indicate the screen, needs to be very highly trained when the test is done in a traditional way. Why? Because we are human beings. We want other human beings to succeed when we pose them a task. And so if we are not adequately trained, we give hints, and the test is skewed. Here we had the need to put the test in the hands of people with minimal training. So how did we do it? By completely redesigning the interface. In the next video, you will see Andrew demonstrating the test. And what he will do is we'll hold the phone in front of himself so that he can't see the screen. Ask the patient to point in the direction of the fork and swipes his hand on the screen in the same direction the patient is pointing. So the system registers effectively where the patient is pointing with the operator blind to how the test is working. And this effectively renders the test independent from the operator. Now, once we've measured the patient, what we do with a technology that is we've effectively derived from the sightseeing group in Glasgow, what we do is we use the fact that the phone as a camera can see the ambient around, and we use that camera to superimpose to the screen a blur which corresponds to measured visual acuity, so that we can show the patient and the carers of the patient or the peers of the patient how the patient is seeing. This is not just merely for awareness. Think, for example, a child in a school that has a vision impairment. By showing the teacher that there is a blur and how much the blur is, we can show the teacher that that child needs a pen, felt tip rather than a pencil, and we avoid turning what is a vision problem into a learning disability. And so there is a number of applications of this technology. So this for visual acuity. Another fundamental exam in eye screening, retinal imaging. Now, what is retinal imaging? It's looking at the back of the eye. We understand the patient doesn't see, we need to understand why. So one of the things we need to do is look at the back of the eye. Now here in this diagram, the eye is a ping pong ball with a hole. And looking at the eye, at the back of the eye, means looking through the pupil, through the hole, at the back of that ping pong ball. It's like looking into a room from the keyhole. In order to get a map of the room, you need to make yourself a mental image, start looking around the keyhole, make yourself a mental image of what is around. It's difficult. This has been done since the 1800s the same way they do it today, which is this. And every person who wears glasses has had this done. It's been done the same way for 150 years. No evolution whatsoever in the technology. The only evolution since then have been the introduction of the light bulb instead of candles and the batteries to power light bulbs, literally. Now, trying to take this to the field has been challenging. Why? Again, because it's difficult. There are simpler instruments around. This is probably the closest to what we would need. And it's a device that has been available now for quite a few years, cost on the order of £1,000-ish. It is simpler to use than the traditional technique. You see the patient and doctor are not so close. Importantly, it has an eyepiece. And this means that to the eyepiece, we can attach a mobile phone. In our case, we didn't want iPhones for technical reasons, nothing to do with the brand. So we attached it to a Samsung phone, building our own adapter, said, right, let's take this to the field. Let's give it into the hands of operators. Problem solved. No, it didn't work. Why doesn't it work? Because this works very, very well in a doctor's office, but if we take it to the field, we're working under the tropical sun, pupils become tiny, and it becomes horrendously difficult to use. So we went back to the drawing board, redesigned it from scratch, and turned the device, completely new technology, to more or less 3 pieces of printed plastic. And this is how the device works. First of all, it is usable. It's as simple as taking a snapshot, but also importantly, it goes back to what we were saying at the beginning. The phone still looks like a phone. We're not pointing anything strange into the patient's eyes. And so it's actually more friendly to the patient. This photograph that was taken a few years ago when we did the first BBC release, that was, I think, end 2012, and that was generation 2 of our device. Now we're at generation 6, and this is an image an operator can take after a few minutes of training. Now, we've recently concluded a crowdsourcing campaign to make this device available to the general public, not just to us for research. The interesting thing that this campaign told us is that there is extremely high interest, not only on low-income countries, but here in Europe. And the reason is pretty simple. It's simple to use, but also screening will become an important issue here. Think diabetes. Every person with diabetes needs their eyes checked. Think how many people with diabetes there are around. Can a healthcare system screen all these people in a hospital? No, not really. We need to go into the community. And so this tool is becoming important here. And simply on a probatory crowdsourcing campaign, we received pretty decent success. Further issue. Now, we've done a set of tests. We need to keep patient records. Now, in a country like Kenya, there are no addresses. Addresses have no meaning, but also names have no meaning. Culturally, people tend to change name quite often. Dates of birth have no meaning. People don't know it. So what do? We tag the exams with a GPS location. This allows us to identify where the exam was taken. Importantly, once we have a database of the GPS locations, imagine a batch of lenses comes in for cataract, we can search the database for the patients who would benefit from that treatment, and the GPS location drives us back to the patient. Importantly, however, this database does another thing. You see those red dots. Those are the patients. You see also those blue dots. Those blue dots are reference points in the community. Think village chiefs, witch doctors, teachers. So importantly, with this database, we capture the community structure, and we enter into the community at the appropriate level to then trace back the patients. So where are we standing now with this technology? Peak exists now as a few tens of units, which are now being used in a number of countries. They're effectively now solar powered. You can recharge them while you're transporting them from one village to the other. And we can do tests in patients' home, such as on the bottom picture. And I've taken that picture up there in Kenya more or less a year and a half ago. You can see there a typical user situation. The lady with the pink skirt, we were looking for her. We had the GPS location. We didn't find her. We were just going back to base, and we met her on the roadside. And there we are doing a complete battery of tests, literally there and then on the roadside. So where are we standing now? Again, we have a few tens of units in the field. We are operating now in a number of countries. We are in Mali, Malawi, Tanzania, Botswana, Madagascar, a couple of test sites in India, a few more opening up. And I think the most recent pilot study we've just concluded is a pilot in 30 Kenyan schools in which we have managed to screen more or less 20,000 children over a span of 9 days by giving PEEK to the school teachers and giving them more or less an hour of training each. So, of course, all this requires money, and we have a number of supporters. The core of our money is coming from the Queen Elizabeth Diamond Jubilee Trust. And importantly, in this moment, PEEK is essentially a collaboration between institutions. There's London School of Hygiene and Tropical Medicine that leads the project and provides the field expertise. There's us in Strathclyde. We develop the hardware bits that go onto the phones. And there's the Glasgow Centre for Ophthalmic Research that develops tests and, importantly, develops specific tests for children. Here, some data to know something more. Please be aware that that Twitter handle is the correct one. The one that is reported on the Lanyard app that has been distributed for this meeting is actually wrong. This is the correct one.
Brilliant. Mario, thank you.